So as we discussed last week, CKD, imagine the oliguric phase of AKI. That's where CKD patients are permanently, forever, unless they, of course, get the privilege of a kidney transplant. Then yes, they will. They're back to they get a reset. Okay. But once they have CKD, the only way we can keep them alive is, of course, treat them the same way as the oliguric phase of AKI, which are what? How do we take care of these patients? Because uh, if needed, dialysis. No, we're still talking about CKD. Okay, so CKD. We'll get to ESKD in a minute. So restrict the fluids, and what else do we restrict? Okay, the diet. Okay, so the proteins especially, and then the why restrict proteins? BUN creatinine comes from, okay, so BUN especially comes from protein. And we control, what do we do about the blood pressure? Because they're in fluid overload. Okay, so medications, tons of antihypertensive. Do we give diuretics as well? Yes. And then, of course, dialysis if needed. Now, because we talked about the erythropoietin, correct? So what will they receive to, maintain blood counts? If needed, we'll give transfusion, but we don't just transfuse. We have to give them something to increase the production. Yes. Go ahead, Mira. What is that injection? Okay, epoetin alpha. That was on the lecture last week, right? You saw that on the management. So that was a subcutaneous injection. We give them about 20,000 units of epoetin alpha once weekly, subcutaneous injections. Okay. And the bone disorder, remember, they get bone disorder, so they'll be given phosphorus and calcium. Okay. All right. Okay, let's go now to ESKD. I described this, right? Chart last week? Yes, okay. All right. So here's the erythropoietin and the diet restrictions. Okay. Let's go to dialysis now. So once they reach ESKD, which is stage 5 of CKD, now they're going to need dialysis. Now there are 3 types of dialysis. The most common type is hemodialysis. The other type is peritoneal dialysis. And then the last one is CRRT, which is only given to, it's still hemodialysis, but then it's only done in the ICU because these are unstable patients, meaning we normally do hemodialysis over 2 to 4 hours. For critical care patients, their dialysis will be over 23 hours, right? Because their bodies are, they are so unstable that their bodies can't handle large fluid volume removal at one time. So we have to gently remove the fluid every hour. Okay, so that's why it takes up to 23 hours. So what is dialysis? So this is an artificial way of performing the kidney functions. Obviously, these patients' kidneys no longer work. So we need an artificial means to serve as the patient's kidneys. So this will be accomplished, of course, externally. So we will describe and discuss our nursing responsibilities, what are the complications, and what are we obligated to do when taking care of patients receiving hemodialysis. Now, just a heads up, we are not going to discuss how to do hemodialysis because the NCLEX test plan, have I showed you that before? Okay, so let's open it. I'll just spend 2 minutes to discuss it. Okay, go to ncsbn.org. So what is this website? This is the National Council for State Boards of Nursing. These are the people who administer your exam. They do not give you the license. It's still the State Board of Nursing for New York, California, wherever you're taking the test. They're still issuing your license, but these people are the ones who develop the exam. Okay, and of course we have different testing centers. The testing center the location won't matter. For instance, when you graduate, you have no plans of staying in New York. You're going to, let's say, I'm going to practice in Florida, but you still have to take I advise that you apply for and take the New York State because that's where you graduated, just to simplify the paperwork. So you apply for licensure in New York State, but the testing venue doesn't have to be in New York. You could be in Hawaii, for instance. You're on vacation, you go to Hawaii. There's a testing center in Hawaii. You go to Saipan, Guam, any tropical country, or you go down south to Florida. That's where you study, you prepare for your exam, and you take it there. Doesn't matter. Okay, so the location of your testing center, because we have testing centers everywhere, will not matter. They still report your results to the same National Council, and then once your State Board of Nursing, where you applied for licensure, receives the result, they'll issue your license. Okay, and then if you want to transfer, then simply apply for transfer to a different state. You don't have to take multiple NCLEX exams. Does that make sense? Okay. So it's not true. We heard rumors that if you go to California, you have to take their State Board of Nursing. That's baloney. Okay, that's not how the system works. It's the same NCSBN. All right. So they work for all of North America. So you'll see if you click on the first tab, you'll see, and then go to the first tab, NCLEX. So you'll have the exams here, right here, test plans. Okay, so you look for this check right here and click on this test plan. Now there'll be two versions. There's a French and English version because North America also covers Canada, correct? So the Canadians take the same NCLEX. Obviously, their version will be in French. So that's why there's French and then there's English. Now, this is for the PN. You don't want that, so you want the RN. Okay, so when you download the document, it's a 59-page PDF. So I'll show you the dialysis here. Right there. So the NCLEX specifically says you're going to be tested on what dialysis. This one says peritoneal, but there's more items. Okay, so hemodialysis. So did it say administer dialysis? No. No. However, under peritoneal dialysis, it says here perform. So are you the one doing it? It says perform. You're the one, but which dialysis though? Peritoneal. Okay, so we'll describe that today. That one is easy. The hemodialysis, however, you need training, meaning entry-level nurses are not expected to perform hemodialysis, but entry-level nurses, are you expected to perform peritoneal? Yes. Yes. Okay. So here, if you look at the document, so all it's saying are perform and manage for peritoneal dialysis. And then for hemodialysis, are we the ones doing it? No, it's just managing the care, meaning you prepare the patient before and then after hemodialysis. That's the limits of our role. Does that make sense? Okay. And then you can also hear, so last week we did central lines, correct? Was it last week? Yes. Yeah. So here, if you're asking, so why did Mr. Escarda demonstrate, and discuss about central line. So here it is. So it says here, access or maintain venous access devices. And I showed you the Huber needle, right? Because we're the ones sticking that needle into the port. So here, assist in, the insertion. Okay, so here, and then you're going to access it and then maintain. So what's part of the maintenance? Is it the flushing? Is it the changing of the dressing? All right, so that's our role there. Yes.
The NCLEX test, it's the same everywhere in all states?
Yep. Because
we
if
showed
there's
this
no,
2021.
no, this was, I'm sorry. What did you say?
Because the date of this regulation is 2021.
Where did you see 2021?
The line is at the bottom, it says 2023.
No, this is 2023. Yeah, because they no longer, if you say 2021, that would be crazy because they wouldn't publish it anymore because it changed every 3 years. It changes. So 2026 there'll be a new test plan. So this is good until March 31, 2026. Yeah. Okay. Did I answer your question?
Yes,
Okay.
thank you.
All right. So central lines. So here, that's why we discuss central lines. Okay. So this is what I mean by schools pick the topics based on the NCLEX. Meaning, am I going to teach you something that's not here? Exactly. What for, right? Because you're taking the NCLEX, so it should only be items relevant to the NCLEX. All right. Okay, so what do we need to discuss today about dialysis?
To perform
Okay, we're gonna perform peritoneal, but then for hemo,
how to manage.
yeah, so we need to know how to prepare the patient because you're the one sending them. So the dialysis nurse will call you and then say, okay, how's your patient? Is she ready for dialysis? And then you have to be prepared. Okay, so what are your responsibilities before you send that person to the dialysis center? And then what do you do when they return to your unit? Okay, any question?
The peritoneal, can't the patient do it themselves at home as well?
Yes, so we'll get to that.
Okay.
Right? So let's start with hemodialysis first. So hemodialysis can be, as you saw in AKI, did AKI patients receive hemodialysis? AKI. It was mentioned, yes. If the azotemia, meaning if the waste products are high enough, remember it mentioned about asterixis, okay, if they have those symptoms, meaning that's they already have encephalopathy, for instance. Okay, so because of severe metabolic acidosis from the waste products, yeah, we can subject them to, we can treat them with short-term hemodialysis, okay? So the average, okay, would be about 3 times a week, about 3 to 4 hours each time. It can be shorter. Really, the decision of how long the duration will be is based on the patient's tolerance. The patient can't handle it. Say the blood pressure is dropping too low. Are we going to continue with fluid removal? No, that's not safe. So we terminate the procedure. Okay. So as described here, HD can be performed at home. This is now in the, I would say, beginning 2005 onward. So they developed smaller hemodialysis machines now, which patients can do at home. However, since they're done at home, they're not going to be able to remove the same amount of fluid and waste products as a larger machine. So if it's a smaller machine, the ones they use at home, then we're not removing enough fluids, okay? Because they have to do it daily as well instead of 3 times a week. But again, that part, are we responsible for teaching the patient that? If we ourselves can't even do hemodialysis, are we responsible for teaching the patient? Oh, we don't know how to do hemodialysis. So can you teach the patient how to use the machine? No, okay? So no for hemodialysis. So these are the processes by which how the dialyzer works. It works by ultrafiltration, diffusion, and dialysate. So we're using a machine and then a dialyzer, and then the dialysate which is the solution they use to perform the ultrafiltration by using the principle of osmosis. I'll describe it a little bit more in detail shortly. So what is osmosis again? Movement of water from low to high. Okay, so therefore, what do you think is the concentration or the osmolarity of the dialysate that they use in dialysis, hemodialysis? Is it hypertonic or hypotonic? Because the objective is to remove excess fluid from the patient's body, because their kidneys can't do that anymore. Well, it won't have sodium. It'll be other hyper, right? Okay, so this dialysate solution is a hypertonic solution. So it will work by osmosis. It will remove water from the patient's blood. So as the blood, let me just describe, I use a video just to describe to you how it works. But again, we're not performing the procedure. Because I spelled it wrong.
Some automakers believe less is more. Genesis isn't one of them, with features that the competition. Your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly. Healthy kidneys filter out waste, excess fluid, and electrolytes like potassium. Of urine. If you have kidney disease,
Let's start over.
your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly. Healthy kidneys filter out waste, excess fluid, and electrolytes like potassium and sodium from the blood. These waste products exit the body through the urethra in the form of urine. If you have kidney disease, your kidneys gradually lose function, leading to an accumulation of harmful wastes and excess fluid in your body, increased blood pressure, and bone or blood problems. Dialysis can also be done to treat acute kidney failure, which occurs when your kidneys stop working suddenly, or to remove drugs or poisons from your body. In one type of dialysis, called hemodialysis, your doctor will use a machine called a dialyzer to clean your blood outside your body. Some weeks or months before you begin hemodialysis, your doctor will prepare a vascular access site on your body. Your doctor will create either an arteriovenous graft or an arteriovenous fistula to access your bloodstream. To begin, he or she will numb the area with local anesthesia. To construct an arteriovenous graft, your surgeon will make a small incision in your forearm and insert a soft plastic tube called a graft to connect an artery to a vein. To create an arteriovenous fistula, your surgeon will make a small incision in your skin and connect an artery with a vein to make a larger vessel called a fistula.
So a fistula means it's a connection. Okay, so fistula is a connection. It's an abnormal connection. So this is an example of a fistula. It's called a arteriovenous fistula. So surgically created in order to create a large vessel. So that way, once we have a larger vessel, we can repeatedly poke that with a needle. Okay, because we need to put in 2 needles. So if it's a good size blood vessel, like a fistula, then it can withstand repeated needle sticks. Because otherwise, can your regular size veins and arteries withstand that? No, impossible. Okay, so we create a larger vessel, an abnormally large vessel. So this will be the size now, well, it will vary. Can be the size of your thumb or as big as this remote control here, because they mature, they grow longer, bigger as they mature. Of course, which side is higher pressure, the arterial or the venous side? The arterial. So if you expose a vein with an arterial pressure, what will happen to the vein? It will grow. So that's what makes it grow. Okay, so the venous side of the fistula grows, becomes bigger. Now you can stick it repeatedly.
To begin, your dialysis nurse will insert 2 needles into your AV fistula or graft. Once the circuit is set up, your blood will flow slowly out of your body and through the dialyzer. Inside the dialyzer, your blood will encounter filtering fibers and an absorbent cleaning solution called dialysate. The fibers will remove waste and excess fluids and electrolytes from your blood. Your cleaned blood will emerge from the dialyzer and continue through the tubing back into your body through the second needle at your access site. When your hemodialysis session is complete, the needles and tubing are removed and you can go home.
They typically just apply a Band-Aid or apply a pressure dressing over it, and that's it. Just one of your responsibilities is to watch the site for bleeding and infection. We'll go into more detail back in the textbook.
In another type of dialysis, your doctor will use the membranes lining your abdomen, called the peritoneum, to clean your blood without removing it from your body. Before you begin peritoneal dialysis, you will have an operation to implant a soft tube called a catheter. Your surgeon will insert the catheter near your belly button, creating a port through which the dialysate will enter and leave your abdomen.
Okay, so the catheter is left in. So it's inside the peritoneum, usually sitting here in the lower abdominal area, and there'll be a external part of the catheter which will be hanging out. Now, as you can see, is the peritoneum only one pocket? No, because there are abdominal organs there. So you have your bowels, you have your stomach, you have your liver, and of course the fluid inside, because we will be putting this fluid, you see this bag here? That's a 2 to 3 liter bag. We're going to infuse that into the peritoneum. So of course, all this fluid will be scattered all over the place. So it's important that the patient moves around when we drain that fluid later. Okay, so the video will describe the exchange. Okay.
Each peritoneal dialysis session is called an exchange. First, you will use your catheter to fill your abdomen with dialysate for a period of time determined by your doctor.
That's usually 10 minutes. Inflow there are 3 phases in an exchange. One is inflow, and then dwell, and then outflow. Again, inflow, dwell, outflow. Inflow takes about 10 minutes to put the dialysate solution into your abdomen. And the dwell time can last anywhere between 2 hours or more. And then the outflow will be about 10 minutes at least, or probably a few longer if the abdomen still feels heavy.
Through the peritoneal membrane, waste products and extra fluid are continuously drawn out of your blood into the dialysate. Along with the waste materials it absorbed, the dialysate will drain out of your abdomen into a disposable collection bag during your exchange.
Okay, may sound simple enough, correct? However, the patient has to do this. One exchange is what approximately, so if it's 10 minutes inflow, 10 minutes outflow, and 2 hours for dwell, how long does one exchange last?
220?
How long?
You said 2 hours.
So approximately, let's say 3, right? Because you have to prepare the bag and the tubing anyway, and the, you know, and the dialysate. So about 3 hours. You have to do this about 5 to 6 times a day, 5 to 6 times a day.
A day or?
It is not once a day. This is 5 to 6 times a day. Yeah, I mean, you're not stuck to a dialysis center. You can move, okay? You can go on a trip. You can visit relatives, but this is what your life is going to be. So if you choose this type of dialysis, it's going to be like that. It's going to be 5 to 6 of these. The last one will be overnight. There is an automated one wherein people like you and me, you know, we were busy, we go to school, we go to work. There is an option to have an automated type wherein you do it with a machine. The exchange is done by a machine. You still connect it to a catheter, to the catheter, and then you go to sleep. So the peritoneal dialysis is done overnight as you go to sleep, about 8 hours long. Okay, so that's something convenient. That's another option to as to doing it manually. So this is the manual option. Okay. You can do the APD, but again, the APD, the automated peritoneal dialysis, of course, is not as efficient as this one, because this one is done how many times? At least 5 times. So compared to only 8 hours, which one is more efficient? I mean, which one is more effective? The 5 times. Okay.
Guys, welcome to Forward. We're a new type of doctor.
All right, so you have an idea. So now let's go into the responsibilities of taking care of patients. So let's start with your responsibilities over the vascular access. So for hemodialysis, the video mentioned 2, right? We have a graft or a fistula. As to which one the doctor will use depends on how soon you need it. A graft is usually preferred if you need it right away and you have no other means to do so. Let's say the patient, because we can do it with, remember when we talk about central lines? So a hemodialysis catheter is a central line. But again, what was our concern with the central line? Okay, so if a patient has high risk, let's say a patient lives with 12 cats at home, is it a good idea to have a central line? No. So we look at the patient's risk factors. Okay, what's best for the patient? So the doctor and the patient talk about that, and then they come up with what's the best way to do this. Because we don't want to disrupt the patient's everyday life. You know, it's already disruptive as it is, because now they have to do dialysis at least 3 days a week. So it's either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. But there's always the as needed part. Let's say this patient misses even one hemodialysis session. That could also already cause them to be hospitalized. Okay, so that's how bad it can get sometimes. So let's begin with the fastest way would be the patient will have a dialysis catheter. You still remember the tunneled and the non-tunneled? So if it's a non-tunneled, does it last long?
No.
How about a tunneled one?
No.
Okay, that one will last longer. So what is this picture of? Is this a tunnel or a non-tunnel? This obviously is tunnel. See, here there are 2 insertion sites. One here, one here. So it entered the body here, it tunneled under the skin, it entered the blood vessel, the central vein right here, right? So this, and here's the tip of your catheter all the way to the superior vena cava. So that's obviously a tunneled hemodialysis catheter. And here's the graft versus the fistula. So fistula can't be used right away. It takes time. How long? I have no idea. It varies from patient to patient. So at least 3 months is the minimum before this thing can mature and can be therefore used. But some can take up to 2 years before they can mature and won't be used until then. Some of them, unfortunately, never mature. Okay, so it's just a matter of, you know, we just let nature take its course to see if this thing will mature and when.
So, they're waiting for the fistula to mature. How would they receive dialysis?
Okay, that's why we have the catheter,
Okay,
or they can also
Do the
opt
graft.
for a graft. Okay,
that's why you can't take the blood pressure, right?
correct.
Okay.
So obviously discussed here, which one is the most long-lasting type of access? It will be the fistula. Okay, this thing will have the longest useful life. Because how long will this patient be on dialysis? Forever, unless again they get a transplant. Okay. So the graft can be used immediately after creation, after implantation, but they don't last long though. That's the problem with a graft. So here's your first responsibility. Whenever you have a patient admitted and they have a fistula, so what should we do? What does this say? You have to let everybody know. Can we just tell everybody, hey, everybody on the shift, hey, remember, this guy has a fistula, okay? Hey, Katerina, this patient has a fistula, okay? Is that enough?
No.
Okay, we put it everywhere. We put signs up on the wall, by the door. Okay, so we let everybody know. Please make sure your sign sticks. Okay, so if you half-ass tape it and then it falls, now what?
They won't know.
Right, some patients are aware, you know, they're alert oriented, but some are not. So not all patients can tell the staff. Let's say someone comes in, had no idea, the sign fell off. Now uses the arm with the restrictions, and patient is demented, has dementia, Alzheimer's. So can they warn the staff? No. Okay, let's go straight to complications, and the responsibilities, of course, are implied here. There's no chart, but there is some bullets. Okay, so let's go here. Because we only do dialysis 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, what happens in between dialysis days? So what's happening to the patient? Fluids are accumulating, waste products are accumulating, okay? Electrolytes are, you know, accumulating as well, right? So there's imbalances in between. So should they miss any session at all?
No.
Because think about it, if they do Monday, miss Wednesday, the next dialysis is now Friday. So how many days did they go without fluid or waste removal? 4 days at least, okay? So that's dangerous. And when we remove large amounts of fluids in a short period of time, do you pee all the, let's say, we're supposed to pee 2,500 ml, right, a day. Do you do that in 3 or 4 hours? Now what's happening in hemodialysis? We're removing all of that within 3 to 4 hours. So of course, what's gonna result? Okay, blood pressure usually drops. So one of your responsibilities is, remember, what are these patients on? What medications are they on every single day? Antihypertensive medications. So along with the Foslo, the calcium phos binders, and then the diuretics. So what should you do with those medications on the dialysis day? We typically don't give them. Okay, so hold them. It will be an automatic hold because of this side effect here. This is expected every hemodialysis session. So that's first responsibility, is to hold any blood pressure medications. So this can happen because, again, of the rapid fluid and electrolyte removal. So during the session, patients may complain of muscle cramping. So these are a result of your electrolyte imbalances happening during the session. And remember the nature of what they did here. So let's go back to the picture of the graph and the fistula, which I don't have anymore. Remember the, let's look at a, so this is what it looks like. It may look ugly to you, but if you're a dialysis nurse, this is beautiful. Okay, because it's very easy to stick. Okay, of course, the patient will the patient be proud of it? Of course, they're gonna hide that, right? They're gonna wear long sleeves over that arm, for instance. Of course, some people will understand, most would not, correct? Like, what is that? Let's say you have kids running around. Hey, what happened to your arm? So look at the, let's look at the drawing. Let's look at this one. Look at the what the surgeon created. So here's the artery. So that means as blood flows here, does all the blood go straight here into the hand? Can some of it leak to the other side and go straight back to the vein? So what will happen to blood flow to the rest of the arm distal, to the rest of the arm distal to the fistula? Say I have a fistula here. What will happen potentially to the rest of it? Do I have enough oxygen and blood getting to there? Okay, so that's what we call steal syndrome. Steal as in you're stealing, money. Steal, S-T-E-A-L. So steal syndrome can occur. And how do you think that will feel? Okay, so any sensation that will result from poor blood flow. Will it look pale?
Yes.
Can I have some, hopefully not black, it'll pale. Okay, so it look pale. Can it lead to like paresthesias, like, because there's not only oxygen but also electrolytes won't get there. So can I have some tingling, numbness sensation there? Okay, so watch for those. You should report steal syndrome because the doctor can do something about that. Exsanguination. So this is when the needle, of course, because it's not a soft catheter that we're using for hemodialysis. It's a needle. Just like when you're giving blood, it's a steel needle. Same thing here. So they use a steel needle during the entire procedure. So of course it can poke through the vessel, and then now we have exsanguination, which will cause a hematoma around the site. Arrhythmias, obviously from the electrolyte imbalances. We'll discuss electrolyte arrhythmias more on module 8. Air embolism can also occur. Air can enter the system, the tubings. Chest pain, and dialysis equilibrium syndrome from fluid shifts. What are the signs and symptoms here? The patient will be complaining of a headache, nausea, vomiting, restlessness, decreased consciousness. So let's say, how am I testing this topic? So complications of hemodialysis. So in clinical, how would this play out? say you are taking care of a patient on dialysis, so that you can imagine how the test question will go. So how will this apply? So what the likely scenario is, you walk into the patient's room, will you see them having these manifestations?
Yeah.
Yes, so how will you study this? Will you look for,
Confusion.
so you have to know the signs and symptoms, okay? So signs and symptoms, and then do we end there? Do you high five yourself? Like, ah, good, I knew it. I found it was disequilibrium. I knew it was disequilibrium syndrome, okay? So now you're gonna clock out and go home. So what's the other question you could prepare for? Well, you did. You assessed the patient. You saw what it was. Okay, so oh, this is, I saw this in the textbook. Okay, so you have to know what your corresponding actions are. So what next? Okay. Yeah, what do you do? A what? Okay, we'll get to the management. So here's the interventions now.
So wait, if you go in there and you notice that, you tell the doctor?
Oh, well, the interventions are next.
Oh,
Okay, so all right. So we know the complications. Now let's go now to what do we do? Okay. So again, look at the manifestations, be aware and knowledgeable about the potential complications of people going to hemodialysis. So first one would be, now because of the dialysis again, so what do we do with medications again? All right, so here's the explanation and what medications. So most medications are dialyzable, meaning can be removed by hemodialysis. So obviously, what medications groups or types are dialyzable? Are they those that are absorbed in the bloodstream or not absorbed? Obviously, those drugs that are absorbed in the bloodstream. So is it okay to apply any other medication that is not systemically absorbed? Yes, so you can do patches, right? So are they okay to give? Yes, because they have, yeah, there's some systemic absorption there, but minor. Okay, so it's okay to give others that are not absorbed. So let's say some antibiotics are not absorbed. So let's say a patient has C. diff, and let's say metronidazole, some certain antibiotics used to treat that are not really systemically, as long as they're taken by mouth. It's different if you give it IV. So here, so if patients are receiving, let's say, especially antibiotics, they're typically given, because remember, can the patients get rid of the drugs without kidneys?
No.
So what happens to these patients' dosaging and timing of the medication therapy? Let's say they need antibiotics and they're on dialysis. Are they given the same as ordinary people? No, we have to change. The doctor has to change the timing. So let's say these patients are on IV antibiotics. Typically, they are given on dialysis days. Make sense? Because otherwise, can the patient get rid of the drug between dialysis days? No. But of course, you'll be notified about that. You don't have to memorize which drugs you have to do. The pharmacist and the physician will notify you. Okay, so which drugs should be given during dialysis days and which ones can be safely given even on non-dialysis days. So here's the discussion we had earlier. Okay, so blood pressure medications typically held on dialysis days. You already know this, so what do we do again with the diet? All right, restrict. Okay, remember there are fluid restrictions here, and the protein and electrolyte restrictions as well. Okay. Psychosocial, I typically don't need to discuss this because how do these patients feel? And what psychosocial issues will these people have? I mean, this is forever. You have disturbed body image, what else? Anxiety, they have social isolation. Yeah, so they're, you know, at the dialysis center, their friends are out drinking at the pub, right? So you know how to address those, right? So what's your nursing intervention for people with social isolation, body image disturbance, depression, ineffective coping? What's your number one nursing intervention? Is it education? Yeah, we educate, but what's the, yes, somebody's, how do you do that? Do you even have to say anything? Okay, yeah, so listen, okay, so spend time with the patient, allow expression of feelings, okay? I'm not saying you have to be a therapist, no, just sit there, you know, listen, and then what are the therapeutic communication techniques to get them to talk? Okay, tell me more, what else? Rephrasing, right? Just be careful with rephrasing. Sometimes some students overdo it, like repeat everything, you know, the patient says. You might get smacked. Okay. For people who need to travel, patients need to be aware to notify their nephrologist. Because it's not easy to travel or relocate when you're on hemodialysis. It requires months, if not weeks, to prepare because you have to find a nephrologist wherever you're traveling to. Can these people go into the woods or mountain? No, that's because they need the dialysis, right? So they can't be off grid. They have to be like near a facility. So they have to understand that. And here's your summary for teaching.
Even if it's not the country, you could offer it.
Yeah, because every country has, as long as there's medical facilities, yeah, there's bound to be dialysis available. Correct, yeah. It may be expensive because it's another country, so everything has to be out of pocket. They won't take your Medicare.
Wow. What about applying for Medicaid, Medicare up there, insurance?
Well, good luck. You're not a citizen. Okay. Let's go to the access site. So we just completed the teaching. So we know about the medication. You're going to be assessing for the, right here.
That was 1579.
Okay, here, page 1590. So this is something you assess every time. You have to check for the bruit and the thrill. A bruit is heard. So how do you assess a bruit? A stethoscope. A thrill is palpated. Have you ever, okay, when your phone vibrates, okay, when it's on vibrate, how does the phone feel? Zoom, like that? Okay, that's literally what a thrill is. So when you feel the AV fistula, you will feel a thrill. It's like a cell phone vibrating. Okay? So of course, it will vibrate commensurate, the same timing as a pulse. So as the pulse is felt, the thrill is also felt. All right. What is your responsibility if there is no thrill or bruit? Okay, that's an emergency. You call them right away. Don't delay because does this patient need this? Their life depends on that AV fistula. You can't feel it, that means can they get dialysis?
No.
Not through there. So now we have to prepare, right? Patient may require a central line, a catheter, short term. Meaning we have to fix that. Okay, someone has to assess that. Try maybe usual cause is there's a clot, so that one's easy, so they can declot it, or sometimes it's stenosis, so they can dilate it. Okay, so either way, you need to notify the physician. Always be careful. Remember, these patients are on fluid restrictions, correct? Keep in mind, this goes for oral and especially IV. Are we clear? Alright. So advocate for your patient. Sometimes doctors order it, and you sometimes may think, especially if you're new, you say, oh, you'll just carry out the order. No, you question the order, right? I see it all the time. And sometimes you see, like recently, maybe 2 weeks ago, I had a patient who was on dialysis, and then they ordered fluids, and before I can pick up the phone, the order changed. No, they DC the order. Okay, put the phone down. Okay, they figured it out. Heart failure, right? Already. So I can test you on heart failure, which is fluid overload, correct? Okay, so you can disregard the pericarditis for now. So just focus on the heart failure, because can these patients go into heart failure? Yes, no kidneys, so fluid overload, heart failure. So we'll discuss the pericarditis and the life-threatening complication for module 8 also. Okay, so that's module 8. All right. Okay, and then of course protect them from infection. Are these patients at risk for infections?
Yes.
Yes, because why? Yeah, because how often do they get stuck with a needle? 3 times a week at least. So of course, do they visit a facility to do that? So are they at risk for hospital or healthcare associated infections? Yes. So are they candidates for pneumonia and flu vaccinations? COVID vaccinations? Yes. So here's your care for the access site. You already know limb precautions. Don't bother that with needle sticks or blood pressure readings. We'll skip the kidney surgery because this involves transplantation. Oh, wait a minute. I skipped the peritoneal. All right. So here's peritoneal dialysis. So I described to you the exchange. We need, as to what type of dialysis the patients get, either hemodialysis or peritoneal, the patient and the doctor discuss the option, and the patient ultimately decides. Are we clear? Okay. So here's the advantages and disadvantages for each. So this would be a nice question, right? Okay. So advantages of peritoneal, they're not stuck to a facility. So they can travel, like I said, because they have, I'll tell you how this works. So I have a few patients who had this back in Florida, and I see them at the grocery store. I can tell that they're doing it during the dwell time because, of course, they're walking around, they're doing this. They look pregnant, okay, because they put, imagine 2 liters of fluid into the peritoneum. So, of course, it's enough to distend your abdomen, right? So, yeah, they're walking around. Yeah, how you doing? Yeah, of course, I don't mention it because people may overhear us. But I know they're during the dwell time. So, they're doing shopping, grocery errands, or going to the bank, whatever you need to do during the dwell time. So, it can be done. Let's say you can even go to Disney World, right? Because can you do the poll and then just go to a bathroom, for instance, and then put the liquid in, okay, 10 minutes, and then get out, and then I can go on a few rides. Plus you have a medic alert bracelet. So do you qualify for Fast Pass? Yeah, so I don't have to stay in line. I get Fast Pass, so I can go on rides. Oh, plus it will benefit me, right? Because I'm supposed to move
No.
around. Yeah, so I'll be twisting around. Ooh. So I can, it's good. I can go on rides, and then later, 2 hours later, I go back to the bathroom, drain it. So it works. It can be done. Yeah. As long as you have proper, hygiene, and then,
If you get an infection,
well, as long as you got a good dressing there, yeah, it'll work. Right, so here are the benefits of peritoneal dialysis. So if you ask, why would someone do that to themselves? Here's the reason. Just can they do this if they were on HD? Can they travel? Not for too long. One day, that's it. And then you can go back to your dialysis center. Plus, of course, there are contraindications. So this could be a test question. So who can absolutely not have peritoneal dialysis? Here are your contraindications. So you know what adhesions are? This usually happens with patients who've had one or more open abdominal surgeries, meaning your organs stick to each other. Are your bowels stuck to each other? No, by stuck, I mean, of course, a bowel is continuous, right? Yeah, of course, that's connected. However, as the bowels loop, did we have a picture here? Here. So these bowels here, are they connected to each other? Let's say the stomach, is it connected to the, let's say the colon? No. Okay, so but they're next to each other, but they should not be stuck. So how do you think bowel movements work? So bowel movements work by peristalsis, correct? So can there be proper or normal peristalsis if they're adhered now? No. Can that cause bowel obstruction? Okay, so if the patient has that, that's one of the contraindications. They can't have a peritoneal dialysis. So if they have chronic backache, so that can be exacerbated. If imagine again, you're carrying 2 to 3 liters of dialysate 5 to 6 times a day. So will this be good? All right, so that's another contraindication. And then same thing here, severe arthritis or poor hand strength. Can they handle this themselves? If let's say they have swan neck deformities, they can't even pull their zipper up. Okay, so that's another one. Or if they're blind. Blind people can probably disinfect and connect, but can they see? Like what color is my dialysate? No. So here's the procedure. Let me go straight to the. Right. So the doctor inserts the catheter, and then once it's in there, it's usually good to go. There's no wait time. You can start using it as soon as the catheter is put in on the same day. And here's the procedure. So an exchange is about 2.5 to 3 hours. So they have a big bag. So how many of these bags will the patient have at their home? Like boxes of it, right? So we see big boxes of these, because how many times do they do it every day? And how many days a week? Okay, so you can imagine how many boxes there are, okay? So there's a lot of these dialysate boxes all over the house. So what could happen if, let's say, hurricanes come and there's a problem with, roads flooded, power lines down, what could happen to the delivery? Can they do it? Okay, so this can be a problem. They run out of their dialysate. Okay, so just consider those logistic issues. So here's the exchange. So 10 minutes inflow, about 2 hours at least for dwell time, then about 10 minutes again for outflow. Now let's go to should they wear gloves here? Yes. Okay, so here are a few things they need to know. The drainage, what color is your urine? Should it be clear or cloudy? Okay. So consider the effluent. So the effluent is the fluid coming out. The dialysate, of course, is the fluid coming in, but when you drain it, it's not called dialysate anymore. It's now called effluent. The effluent should be clear, just like your urine. Should be yellowish, clear. What happens if it's cloudy? Okay, that means, do they have a infection? Yes. What if it's bloody or pink? It depends. Bloody or pink during the, what does this say? First few exchanges. Okay, that's expected. That's okay. However, if it continues to be bloody after a few days of exchange, is it still normal? That could mean what? Bleeding inside. Okay, it could be that we've injured bowels, for instance, or maybe the mucous membrane. What if it's colored brown? What could that mean? The effluent is brown, poop colored. That's bowel perforation. Okay, the catheter may have traumatized and punctured the one or more pieces of bowel. So most serious is the infection. So what are possible indications that the patient has peritonitis? What's the effluent color again? Cloudy. So besides cloudy, and what will be the patient's symptoms? Okay, abdominal pain, tenderness. Take note that the peritonitis is not always going to affect all the entire abdomen. It may be on one side only and then later diffuse throughout the abdominal cavity. So it's important to know that the rigidity may be only on one portion of the abdomen. Doesn't have to be the entire abdomen immediately. Is that clear? Once identified, of course, peritonitis, is this serious or minor? This is serious. This can lead to sepsis. So patient has to be treated with antibiotics as soon as diagnosed. Leakage. This means your dialysate is supposed to go into your peritoneum. Now it's leaking around the site. Okay, so that's a complication. So what are your prevention and management if it leaks? Of course, if it's leaking, you tell the provider. However, to prevent it from happening in the first place, they should not be lifting anything heavy, okay, especially if the catheter is new here, and they maintain that weight restriction. The dialysate bag should not weigh more than 5 pounds. It's usually around maybe 2 or 3 pounds. Okay, so it's okay for them to lift the bag, okay, when they hang it on the pole, when they do the inflow. Yes.
So leakage, the first sentence says that the PD catheter is delayed for at least 2 weeks. But earlier you said that we could use it right away.
Yeah, typically if we're in the hospital, but
Okay.
when they go home, they should usually, yeah. Bleeding, of course, that's reportable. Patient has to notify the doctor immediately. And here are some long-term complications. So we talked about the back pain earlier. Can this cause lordosis? Like your gait is now like this. Yeah, okay, so that can happen. Hernias can also occur. Again, the chronic repeated distension of your abdominal wall because you keep putting large amounts of fluid there. Can that weaken the abdominal wall? Can you have hernias as a result? So I described to you the automated Let's describe how the exchange is done with the automated one. Here's the instruction you give to the patient. So when they're doing the peritoneal dialysis, they should be either ambulating, or if they're, let's say, prefer to be in bed, they should turn around side to side, because we want the dialysate to be spread throughout the peritoneum, because we want the entire osmosis to occur throughout to all the surface of the peritoneum to maximize the fluid removal. If the patient is obese, that means they have a pendulous abdomen, then that would be the instance wherein they're probably sitting in a recliner, because there's shortness of breath here, because now they already have a big abdomen to begin with. Now you add 2 liters, so shortness of breath can occur.
Or would they let someone obese do PD?
I've seen some. Well, it wasn't really a contraindication, right? I mean, it wasn't listed as one of the.
It's not, if they don't move, how is it gonna?
Oh, that's an issue again. Patient has to decide. Okay, we already discussed the complications. And that's it for peritoneal dialysis. Any questions? Okay, take a break. Come back at 3 o'clock.